بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. إن شاء الله هنتكلم النهاردة عن different presentation of potassium disturbance. Our lecture objectives include establish the definition of hypokalemia and hyperkalemia, review the clinical consequence of hypokalemia and hyperkalemia, outline causes of hypokalemia and hyperkalemia, approach to the diagnosis of hypokalemia and hyperkalemia, describe the treatment options to hypokalemia and hyperkalemia. Let's begin with hypokalemia. The normal serum potassium concentration is 3.5 to 5.5 milliequivalent per liter. So hypokalemia is serum potassium concentration less than 3.5 milliequivalent per liter. Let's discuss our case. Our case is a 20 years old female was admitted to the emergency department because of bilateral leg weakness, blood pressure 160 over 110 millimeter mercury, lab test revealed metabolic alkalosis, sodium 137 millimole per liter, potassium 2.3 millimole per liter, magnesium 1.2 millimole per liter, creatinine 0.2 milligram per deciliter, thyroid stimulating hormone and free thyroxine level within normal, and ECG showed U wave. So it is a young female, hypertensive, may have a cause of secondary hypertension, presented with muscle weakness in the form of bilateral leg weakness. Her laboratory tests include showing metabolic alkalosis, hypokalemia, borderline magnesium, and the ECG showed a prominent U wave due to hypokalemia. The patient was treated with oral and intravenous potassium. Her diet was enriched with potassium and magnesium level were corrected. So we are in front of a case, a young female with secondary hypertension, hypokalemia and metabolic alkalosis. So the differential diagnosis of hypokalemia includes three main categories. First, decreased potassium intake, which is not relevant in our patient because there is no signs of malnutrition and hypokalemia was persistent despite continuous potassium supplementation. The second may be due to potassium redistribution into cells. We call it intracellular shift of potassium. Due to drugs including beta agonist or due to hormones insulin. However, all were excluded in our patient by history and the laboratory test. Also, there are two causes of intracellular shift, including familial hypokalemic periodic paralysis, which is also not relevant in our case because in this disease, hypokalemia should be medically corrected by supplementation. And also thyrotoxic periodic paralysis, not relevant in our patient because the thyroid tests are normal, not hyperthyroidism. The third cause of hypokalemia or the third category, which is relevant in our case, is the loss of potassium, including renal loss of potassium via mineralocorticoid excess. Other causes of loss of GI loss of potassium, vomiting, and gastrointestinal volume loss were excluded, and the urinary screening for toxic substance like amphotericin B all excluded, and for diuretics was negative, and the patient denied showing licorice. So the most likely differential diagnosis were primary hyperaldosteronism. Primary hyperaldosteronism including adrenal hyperplasia, Crohn's disease, familial hyperaldosteronism, glucocorticoid remediable aldosteronism, renal artery stenosis, Cushing syndrome, renin secreting tumor, and Liddle syndrome. So a screening test for aldosterone to renin ratio and was performed, and primary aldosteronism confirmatory test also was performed, while a Doppler ultrasound of the kidney was completed with no evidence of renal artery stenosis, and 24 hours urine for cortisol were within normal range, so to exclude Cushing syndrome. After the lab result confirmed primary aldosteronism, the CT also the CT of the adrenal gland showed an adenoma. So we are in front of a case of primary aldosteronism. She was referred to an endocrine surgeon and underwent adrenalectomy. So it is a case of primary hyperaldosteronism, and the patient was treated medical and surgical with complete recovery. So to revise our case is young female with hypertension, so it is most probably secondary hypertension. The patient presented with hypokalemia, hypomagnesemia, metabolic alkalosis, and the U wave in the prominent U wave in the ECG, which is a sign of hypokalemia. We exclude all causes of hypokalemia. We exclude diminished potassium intake, also exclude causes of intracellular shift of potassium, and we confirm renal loss of potassium through primary hyperaldosteronism by doing aldosterone to renin ratio, and confirmed by primary aldosterone, primary hyperaldosteronism confirmatory test. So to revise the etiology of hypokalemia, hypokalemia may be due to decreased intake of potassium or excessive loss of potassium. Loss of potassium may be GI loss or renal loss. GI tract loss as in chronic diarrhea, villus adenoma of the colon, which secrete potassium, or protracted vomiting or gastric suction. Maybe also hypokalemia may also be due to intracellular shift of potassium due to as in total parenteral nutrition and enteral hyperalimentation. There is a stimulation of insulin release. Also after administration of insulin lead to glucose and potassium entry in the cell. Stimulation of the sympathetic nervous system with beta-2 agonist. Thyrotoxicosis, as we see, as we exclude in our case, we exclude hypokalemic thyrotoxic periodic paralysis. Also familial periodic paralysis, which is an autosomal dominant disease, consists of episodes involving varying degree of paralysis. This episode is precipitated by carbohydrate meal or strenuous exercise. Another cause of hypokalemia is renal potassium loss. Renal potassium loss either any cause causing hyperaldosteronism, as in Cushing syndrome, or primary hyperaldosteronism, renin secreting tumor, congenital adrenal hyperplasia, ingestion of licorice, renal tubular acidosis, Fanconi syndrome, and hypomagnesemia. Our case, primary hyperaldosteronism, and there is borderline magnesium. There are also a rare genetic causes of hypokalemia, including Bartter syndrome, which is a genetic disorder characterized by potassium and sodium wasting, and the patient normotensive. Gitelman syndrome, it is also a genetic disorder characterized by potassium and sodium wasting, and the patient also is normotensive. Liddle syndrome, it is an autosomal dominant disease. The patient characterized by severe hypertension and hypokalemia due to unrestrained sodium reabsorption in the distal nephron due to mutation found in gene encoding for epithelial sodium channels subunit. Also, there is many drugs which can cause hypokalemia, including diuretics, either thiazide, loop diuretics, osmotic diuretics, laxative, amphotericin B, penicillin, and sulfilin, all causes hypokalemia. What is the symptoms and signs of hypokalemia? Our case presented with bilateral leg pain or leg weakness. Mild hypokalemia rarely cause symptoms. Serum potassium less than 3 ml equivalent per liter generally causes muscle weakness. So potassium disturbance mainly affect the muscle and may lead to paralysis or respiratory failure. Muscular dysfunction also include cramping, fasciculation, paralytic ileus, hypoventilation, hypotension, tetany, and rhabdomyolysis. Persistent hypokalemia can lead to renal concentrating impairment of the renal concentrating ability, causing polyuria, with secondary polydipsia as and nephrogenic diabetes insipidus. How to diagnose a case of hypokalemia? As we do in our case, we do serum potassium, ECG. In some cases we may need to do 24-hour urinary potassium excretion and serum magnesium. ECG changes, many changes can be found in hypokalemic patient, including sagging of the ACT segment, depression of the T wave, elevation of the U wave or prominent U wave as in our patient, many premature ventricular and atrial contraction, ventricular and atrial tachycardia, even ventricular fibrillation may occur. Diagnosis of the cause, as we do in our patient, drug history, it is important. Acidosis and other causes of intracellular shift of potassium needed to be excluded. Urinary potassium may need urinary potassium level to differentiate between extrarenal potassium loss and renal potassium loss. If urinary potassium less than 15 milliequivalent per liter, it suggests or suspects extrarenal potassium loss or decreased potassium intake. If urine potassium more than 15 milliequivalent per liter, this suggests a renal cause for potassium loss. How to treat a case of hypokalemia? As in our patient, oral potassium supplement and intravenous potassium supplement. A decrease in serum potassium of 1 milliequivalent per liter correlate with about 200 to 400 milliequivalent deficit in total body potassium. Total deficit can be estimated and replaced over several days at a rate of 20 to 80 milliequivalent per day. When hypokalemia is severe, we must replace potassium through intravenous route. The concentration shouldn't exceed 40 milliequivalent per liter, and the infusion rate shouldn't exceed 10 milliequivalent per hour, except in severe cases when hypokalemia induced arrhythmia present. Intravenous potassium chloride must be given more rapid through a central vein or multiple peripheral veins simultaneous. Infusion of 40 milliequivalent potassium chloride per hour can be undertaken, but only with continuous cardiac monitoring and hourly potassium estimation. Glucose solution are avoided. We didn't give potassium on a glucose solution because, as you know, glucose lead to stimulation of insulin, and the insulin will lead to glucose and potassium entry into the cell and the intracellular shift of potassium, which aggravate hypokalemia. When hypokalemia occurs with hypomagnesemia, as we discussed in our case, both the potassium and the magnesium deficiency must be corrected to stop ongoing renal potassium worsening, because hypomagnesemia lead to increased renal potassium secretion. It is important also to prevent hypokalemia. How to prevent hypokalemia? Serum potassium should be monitored during diuretic use, especially in high-risk patients. High-risk patients as patient with decreased left ventricular function, patient taking digoxin, diabetic patient, asthmatic patient who are taking beta-2 agonist. As you know, beta-2 agonist lead to intracellular shift of potassium. If the patient in need of diuretics and he is liable to hypokalemic or who become hypokalemic, we can replace potassium wasting diuretics by other potassium sparing diuretics. Now we will talk about hyperkalemia. Hyperkalemia is a serum potassium concentration more than 5.5 milliequivalent per liter. Let's discuss our case. Our case is 66 years old man, presented with history of weakness of both lower extremities. He had a history of coronary artery disease. The patient was taking aspirin 75 mg once daily, ramipril 2.5 mg once daily. Ramipril is an angiotensin converting enzyme inhibitor, and spironolactone 25 mg once daily, which is a potassium sparing diuretic, for the past year. Blood urea 54 mg per deciliter, serum creat 2.6 mg per deciliter, serum sodium 136 milliequivalent per liter, serum potassium 6.4 milliequivalent per liter. So our patient is an old patient with coronary artery disease. Both are risk for hyperkalemia, the old age and the coronary artery disease. Patient receiving ACE inhibitors and potassium sparing diuretic, which both lead to hyperkalemia. And the patient also has a renal impairment in a lab test and potassium 6.4. An ECG showed tall peaked T wave and prolonged PR interval, which are common finding in hyperkalemia. The patient was immediately initiated on calcium gluconate to antagonize the toxic effect of potassium on the heart. He also received insulin dextrose solution infusion and nebulization with beta-2 agonist, both lead to intracellular shift of potassium, and the oral potassium binding agent calcium lustrine sulfonate were administered, and the patient drugs ACE inhibitors and spironolactone were stopped, and the serum potassium level subsequently normalized after 12 hours of treatment, and the patient was able to walk in the second day. And the ECG taken after correction of hyperkalemia after 12 hours of treatment showed normal sinus rhythm. The patient was detected to have deranged renal function with evidence of chronic kidney disease using ultrasound, which might have contributed to his hyperkalemia. So in our patients, there is many risk of hyperkalemia, including old age, coronary heart disease, chronic kidney disease, drugs in the form of potassium sparing diuretic and ACE inhibitors, all are risk factor for hyperkalemia. On the follow-up after 2 months, the patient was doing well without any neurological symptoms. His serum create was 2.4 mg per deciliter and serum potassium was 4 milliequivalent per liter. So our patient show a good response to treatment in the form of calcium gluconate, beta-2 agonist, glucose insulin infusion, and potassium binding resin. So let's revise the causes of hyperkalemia. Hyperkalemia may be pseudo-hyperkalemia, and we should exclude pseudo-hyperkalemia in managing any case with hyperkalemia. Pseudo-hyperkalemia may be due to hemolysis of the red blood cell in the blood sample, may be due to prolonged application of tourniquet or excess fist clenching when drawing venous blood, may be due to thrombocytosis or extreme leukocytosis. Other causes of hyperkalemia include increased potassium intake, diminished renal potassium excretion in oliguric states such as acute kidney injury or adrenal insufficiency or chronic kidney disease, all lead to diminished renal potassium excretion. Also increased potassium release from cells. What is the symptoms and sign? Potassium affect mainly the skeletal muscle and the cardiac muscle. Also, in a case of hyperkalemic familial periodic paralysis, weakness frequently develops during the attack and may progress to frank paralysis. How to diagnose a case of hyperkalemia? As we show in our patient, we do serum potassium, electrocardiograph, we do revision of the drug use and the renal function, and also we do renal ultrasound to exclude obstruction. The patient at high risk of hyperkalemia, including renal failure patient with advanced heart disease, patient with urinary obstruction, or patient treated with ACE inhibitors and potassium sparing diuretics as in our case. ECG in hyperkalemic patient may show increased PR interval, shortening of the QT interval, tall peaked T wave, widening of the QRS interval, disappearance of the P wave, nodal and escape ventricular arrhythmia, thin wave pattern, ventricular fibrillation, or even S-stole. How to treat a case of hyperkalemia? As we see in our patient, treatment of the cause, we stop drugs which increase potassium, we stop potassium sparing diuretics and ACE inhibitors. Mild hyperkalemia, we can give sodium polystyrene or calcium polystyrene sulfonate, which is a potassium binding resin. We also, in moderate or severe hyperkalemia, we give intravenous glucose insulin to shift potassium intracellular. We give intravenous calcium solution to antagonize the toxic effect of potassium in the cardiac muscle. We can give inhaled beta-2 agonist to intracellular shift of potassium. All these measures we do it in our patient. And lastly, if there is resistant hyperkalemia, patient may undergo hemodialysis. And we should know that peritoneal dialysis is inefficient at removing potassium acutely. شكرا جزيلا.